Hey, welcome everybody. Another podcast, Neuro Way to Practice podcast, and it's Tuesday. That means Jake is with us. Jake, what's the temperature down there in Florida?
It's been a nice day. Not extremely sunny for Florida, but it's about 74 degrees right now.
Well, we're freezing up here.
I'm
About
sorry to
negative
hear that.
6 wind chill. Oh, brutal, absolutely brutal. But
It's an excuse for you to get down here, and we could do a podcast down here in sunny Florida.
and we will do that.
I
Actually,
love it.
we'll be there February 8th, 9th, and 10th. So
Fantastic. Come on over, and we can set it up and maybe even do something in the beach.
sounds good. I'll have the Speedo ready. Okay, now that I just ruined a lot of people's appetites, let's get into the topic for tonight. The topic is neuropathy, number one, and then number two is plantar fasciitis. Jake, what I'm seeing up here is just people coming out of the woodwork. And when I say people, I mean chiropractors, basically coming out of the woodwork, saying, "Oh, we are your neuropathy specialists. We have this amazing treatment for neuropathy. Come in here and treat your neuropathy." And basically, it's laser therapy.
Yeah.
Now, one of the benefits of having your own podcast, you can pretty much say whatever you want to say, so I can kind of vent here. I just think buyer beware a little bit on that. That maybe you should question the doctor on how much neurological classes they've taken in the last couple of years. What would they define neuropathy? Because neuropathy, it encompasses so much. It just means the nervous system is not functioning properly. And are they really getting true to the true cause of what's going on? Is it diabetic neuropathy? Is it a vascular problem causing the nerve not to function properly? And that would be a neuropathy. Is it a conduction problem where the action potentials, the nerve is not firing like it should? Is it that kind of neuropathy? Is it a compressive neuropathy where we have maybe disc material that's butting up against a spinal nerve root? Is it another compression syndrome where we have myofascial that's butting up against a peripheral nerve causing problems? I mean, there's so many things here, but I do know that we treat neuropathy in our office after I do a very thorough history and examination. And by the way, a very thorough neurological examination. But our go-to treatment after spinal manipulations and extremity adjustments is the ARP RX foot bath. Take it away, Jake, and tell our listeners what that is and what it does.
100%. And this is a fun one because it's often the go-to, even to introduce our technology. It's really easy to administer. It's also easy on the patient. Believe it or not, your feet go in water. This is on a direct current wave, so it's perfectly safe and conducive to do so. And the results are astounding because the water acts as a magnifier. And it works so well. There's a reason why we've had podiatry clinics bring this on, because they've seen such great results with it. So if you are a chiropractor out there and you feel like you have been able to treat with neuropathy to some degree, but haven't been able to push it beyond that envelope, this foot bath is it's so successful. Like I said originally, it's the go-to for me if I just want to introduce it. I actually get excited when somebody, not excited, but it's almost a relief when someone tells me they have neuropathy, because it's like, look, we have something for you that I know is going to give you some benefits. So essentially the way this technology works, again, goes with that direct current wave. So we use that to our advantage, and we place those the black leads, that's where the current will start. And then we actually cross the leads to go through the body on the opposite side. So essentially the placements are on the bottom of the feet and then opposite quad. And that's the common placement. And the idea behind that is, as the water is acting as a magnifier, you're getting those contractions on the bottom of the feet that is actually going to, it's essentially looking for that red pad. But at the same time, we can also argue, through a lot of research we've done, even with Kaiser, that it's going to your brain as well. So neurologically, you're also making a connection. A lot of times that we've seen in neuropathy is that if if the muscles are dormant, this does a great job in waking up the muscles and firing it up so that now you can start to feel some of those contractions come. One of the biggest, I guess, aha moments I've had when it was about 5 years ago, we were treating a lady. She didn't feel her legs for 10 years. And this is our introduction in an office to basically show them how the technology works. And within about 10 minutes, she was in tears because it was the first time she actually felt her feet. And, unfortunately, the doctor didn't pick up the unit. So she literally drove 4 hours out of her way to be treated when we left, because the closest one after that, it was in Key West. So she had to actually drive from Key West over to the Miami area to actually be treated. And then she eventually actually bought a smaller unit to treat herself. But again, it's one of those modalities that I love to talk about, because the success has just been off the charts and almost unreal, but the results never get old.
So we've seen the same thing. We will have patients that have come in, and quite honestly, it's been mainly diabetic neuropathy is what we've been treating, and they have had foot problems, pain. They've had coldness in their feet, but even more so, they are losing the sensation in their feet, which is really can be devastating, because if you don't know what's going on with the floor, if you can't feel that with your foot, you're going to lose what they call proprioception. Proprioception is the knowledge of where you are in space and time. And so if you're starting to lose that ability, you're going to start dragging that foot. And next thing you know, you could have a fall. And slips and falls for basically a lot of the age group that we're treating with the diabetic neuropathy, it's the older population. And they've been every place else. The MDs really don't know what to do. PT is don't know what to do. Um, they may have had some success with the laser therapy, but it is not lasting at all. And so we start off with a really good exam, and part of that is a balance test. We got to see how their balance are. If they can't feel things, that's a more severe condition. And so I love doing the baseline balance testing on them. Just both feet down, and then eyes open. We'll see if there's any swaying. And then we move to eyes closed. And when you take that visual aspect away, it usually magnifies the problem. But a lot of times they just say, man, I can't feel my feet. I'm walking along and all of a sudden I trip. I'm getting more clumsy. And prior to our therapy, we didn't have any way to really treat that. I mean, yeah, I could adjust the foot and try to get some sensory stimulation going in that way, but we have seen remarkable results with the foot bath. And it's always funny. I will tell the patients it's counterintuitive. We're going to hook up electrical stimulation to your feet, and we're putting you in water. In their eyes. I mean, you've seen it. I
Yeah.
mean, they just kind of look at you, and they're nervous at first, aren't they?
They are. They almost. It's like, what is this hokey thing that you're bringing over here? Especially when you use it as an introduction. So there has been a case where I treated a sales rep that was with me first to show that we weren't messing around. This was a real deal. And
Hmm.
but it is true. On direct current, it's perfectly safe.
So I bring this up because if you do have or know somebody that has diabetic neuropathy, there is unbelievable treatments out there, and this is one of them. But we're not going to start, to stop at the foot bath. That just gets the ball rolling. Then after we do the foot bath and get some of those symptoms taken care of, we got to move up the leg, because if the foot hasn't been firing appropriately, can you imagine the other joints and the other muscles that have gotten weakened because maybe somebody's been scared to walk or it's been too painful to walk? So we got to go right up that, what we call the kinetic chain, and start searching and see what the other muscles, what they're doing, and then you really have good outcomes. The I love the introduction to the therapy, doing it with the foot bath, because we've had everybody that has tried it, the first time they come out and they feel a difference. They either feel better, but they do feel a difference.
Yeah, for sure. And what I've seen a lot of, especially with the neuropathy patients, is that they notice right away that their balance is better because they're now more aware of, like what you were saying, is where their base is at. They're more aware of their muscles firing up, so they walk better, right from the beginning.
So that kind of leads us into the second part, or the second condition that I want to talk to tonight, because plantar fasciitis.
Mhm.
We Everybody knows somebody that's had plantar fasciitis. Heck, I've had it numerous times when I was doing a lot of running. It is one of the most painful things, especially when you first get out of bed in the morning and you don't know that you have it, and you take that first step and it's like walking on broken glass. It is just a bear to get over. I mean, I when I was coaching baseball at the high school, and we were constantly out, it seemed like every season I had plantar fasciitis,
Hmm.
and it was, finally I had to go with like a steroid. Had to get on steroids to calm the inflammatory phase down. So we see a lot of patients with plantar fasciitis, and you know, can you bring stretch out so you can just show the people real quick
Yeah,
about
absolutely.
plantar
Stretch is
fasciitis?
always happy to be involved with our discussions. So
I thought he was. So we've got the plantar fascia. It's underneath the foot.
correct.
So is it possible can he lift his legs, or is
I,
he?
I can I can lift him up and we can just go like this.
Okay, so right on the bottom there, that white part. I mean, it's a little bit bigger in real life, but that would be fascia, and that's just where the muscles come in and they attach it. Well, that fascia can have little tears in it, become inflamed, and it's all because, Jake, if you'll flip him over and show the calf muscle, the
Sure.
gastroc muscle. Okay, so everybody goes right away to the plantar fascia aspect. It's the calf muscle. That's one of our postural muscles that when we're standing, and if we stand for prolonged periods of time, those muscles will start to ache because they're not getting blood supply. And that muscle needs that nourishment, and they'll start to ache. And then eventually it goes into myofascial trigger points, real tender, taut garbage product buildup in there. And then the flexibility in the gastroc, and it starts pulling on that fascia, and it starts creating tension, and that's plantar fasciitis.
Hmm.
Fasciitis stands for the fascia being inflamed. Um, Sometimes when I'm doing the exam, I will find where it's hot and it's swollen. The majority of the time, it's just extremely tender at the bottom of the foot on the fascia. So we scan we scan the gastroc, and probably 99% of the time we find the hot spots in the gastrocnemius muscle on both sides,
Got it.
and so that's where we know where to go ahead and start the treatment. What have you found with your scans on for plantar fasciitis?
Yeah, for sure. Gastroc is a definitely. Bear with me here. Before I'll hold him here for now. Gastroc's definitely a common one. Sometimes, believe it or not, I'll even go to the bottom of the foot and where the heel is at and the arch,
Mhm.
and we've seen some tenderness there. Popliteus has fired up a few times on me. And believe it or not, I'd even go beyond that, getting into like the center belly of the hamstring.
Gotcha. So we get the pads on there, and then tell you the truth, with plantar fasciitis, I need to get the pain. I need to get them out of pain before I can move them into any kind of rehab. Because if I just go and start engaging on those gastrocs and doing toe raises, that's not going to be good. I got to quiet things down. So we do the foot bath, and patients absolutely love it. Then I will do some ankle adjustments. So once we get their pain that is manageable and they're ready to go into the rehab, Then we put those pads on the gastrocs and we start doing toe raises, everything for the lower extremities. So you want to, I know we've talked about this before, but let's go into this new protocol 40 pulses per second,
Mhm.
500. And what would the protocol be that you would recommend for plantar fasciitis?
Yeah, so if we're talking the middle cross, and again, this would be after foot bath because I have seen a lot of reduction in pain by running through foot bath a few times and then going into the movement. But as far as the middle cross would be concerned, that would probably be my go-to because of the success that we've had. And even the doctor I was working with, he had some Achilles issues. This is why I know it would be successful for that. And we used the middle cross to essentially help relieve a lot of that pain where he can get back into working out. So essentially, and let me just give me a second here so I can readjust old Stretch here
I hope
as
Stretch didn't lose any vital anatomical
yeah, just the glute med, but it'll grow back.
Okay. All righty.
No big deal. We'll get that. We're not going to be using the glute med right now anyway, so he'll be fine. So assuming this would be the black pad, we would essentially go into, if you can look closely here, it would be the adductor closer to the knee, where in that VMO location, but on the adductor, and then it would be the red pad going to the opposite pec minor, kind of like that pec minor delt area, and then you would just mirror the other side. So you would still cross it. It would be on the right side in Stretch's case, and then opposite left pec minor, and you would run all 4 pads in that cross combination. And we would start off with 40 pulses per second. And the idea behind that is 40, we've talked about this before, but 40 kind of zeroes in where that pad placement is at, as opposed to 500 where it's more of that neurological reset. It does a better job in doing that. 40 does a better job in kind of waking that muscle up, getting strength training. We use it a lot for performance. So we run a few sets at 40 with this pad placement, and then we go a couple of sets with 500 on normal polarity. And normal just essentially means, kind of going back to this, that the black is running to the red. So you're running in that direction. We run a couple of sets with that, and then we shut the machine off. We reverse that polarity. So now we're taking that red and it's going downward towards the adductor. And we run 2 more sets at 500 pulses per second. And then we run 1 more section of 40 pulses per second on that reverse, again, running from that pec minor down to the adductor. And then from that point, you can kind of rest. You can have them go on sort of a recovery protocol of light sensation.
Okay, so what's the position of the patient? And then are they laying down? Are they seated? And then what's the exercises you're having them go through?
Yeah, so it's going to vary depending on what the patient, what the patient can do. I'm always going to defer to something that's going to be a movement that would cause pain. So without this machine on, if it's walking, we would do some sort of like step. And essentially they would just do, if you have a stepper, or even if you don't have a stepper, you can just replicate that particular movement as a rep, so to speak. And 9 times out of 10, we're going to get the patient on their feet. Now, if in fact you have a patient that can't really go through those type of movements, you can always have them laying down in a supine position and doing like a plantar dorsiflexion with their feet. Any type of movement will suffice. It's just going to be a lot better if you can get them doing something that's a little bit more real world.
Okay, so people that just jumped on and they just started watching this, they heard plantar fasciitis. They saw you place a black pad on the upper thigh and then up on the pec.
Correct.
And they're going to be going, where's the therapy going to get to the plantar fascia or to the gastroc? How is that going to work?
Yeah. So the theory behind a lot of that, which is actually a great question, is that we believe about 80% of what's caused in pain in the human body has something to do with the middle cross, whether it's anterior, posterior sling, something is involved. Now, in this particular case, we have seen the most success on the hypertonic muscles. That would be the pec minor and then the adductor. There is a secondary placement where we do the hypotonic, Not as common, and that's the one of the reasons why I always go to this. But believe it or not, within that middle cross, that also can attribute to knee pain, ankle pain, and in this particular case, plantar fasciitis. Now, there are other placements you can use. This happens to be my go-to in the recent, just because of the amount of success that we've seen from it.
Okay, so then what you're saying is that the therapy just isn't occurring underneath the pads, that there's a radius that that current is spreading out to, correct?
100%. So, unlike when I was talking about the 40, this neurologically is passing through that entire kind of like your muscles are twisted. It's
Mm-hmm.
passing through all of that, and they're all connected. Not only that, of course, because of it being neurological, now you're helping that brain to reset, kind of retransmit some of those areas that were dormant and help them to fire up so they can absorb force. And of course, if needed, in many cases, it is needed to help retrain those muscles as well.
Nice. Okay, so you start off probably with the foot bath to begin with. Just want to recap, make sure we got
Correct.
those down. Start off, well, first of all, you start off with a really good evaluation. It's got to be a neurological exam, probably checking the vascularity in the lower extremity to see if the pulses are strong. And you're going to do your deep tendon reflexes. You're going to do your motor testing. You're going to do your pinwheel testing. For those that are not chiropractors, that's just a neurological exam. That is a basic neurological exam that should be performed if you're seeing anybody that thinks they know anything about neuropathy. Then you got to go into more of an in-depth neurological exam regarding balance testing. And I guarantee you, everybody that has problems with their feet, whether from diabetic neuropathy, whether from neuropathy or plantar fasciitis, is going to have balance problems because they just can't feel their feet. That is not getting the information where it needs to get to. So you do the foot bath, get their pain under control, get them feeling really good, and now we zero back in because the goal is to get them moving better. We don't want to just get them out of pain, do we, Jake?
No, because that's just kind of like what most people do, chasing the pain, and they're attacking the symptom. We're trying to fix the problem.
So we're going to come at this from a rehabilitation standpoint. We have got to get you moving, and the therapy, the ARP therapy, is going to help with that. And then it's just going to get you moving. And research after research just shows it's the best for everything: mental, physical, the emotional side, everything. It's going to be great to get you moving. So if you know somebody again that has neuropathy or been diagnosed with it or plantar fasciitis, I think plantar fasciitis is probably more common. Everybody knows about plantar fasciitis, and they so if you know somebody, hey, tell them to give us a call and or tell them to come visit the the clinic. So there's that shameless plug.
Love it. I love it. Look at that. He's
God,
a
how did that
man
get
of
there?
many talents.
Okay, so we have been talking in weeks past about female ACL injuries, and we got another devastating story that I want to relate tonight. Um, I'm leaving the names of these kids out, but it's a senior in high school here in Gaylord. She had torn her ACL. I think it was about 2 years ago, maybe a year and a half ago. Anyway, she went through rehab and finally came back, was able to play soccer, and was just resuming her athletic endeavors. And I found out that late last week, the same girl tore the other knee, tore the other ACL. It's going to have surgery, and then go through this whole process. Um, my thoughts on this, without knowing any details at all, but I'm pretty sure it was probably a non-contact injury. That means that there just wasn't enough what we call sensory motor control. So she just was not able to probably stop. I got to imagine it's probably a deceleration injury where she was coming down the court with the basketball, tried to stop. Her body kept moving forward. The knee didn't. And we get a torn ACL. So this goes back to our conversation last week about ACL injuries and about how the muscles, the muscles have got to be able to absorb forces. People, this. It's not that difficult, Jake, right? And it drives me nuts because everybody wants to make it so much more difficult, or they don't want to talk about this at all and just accept it.
Yeah.
And I just think the time for acceptance is over with. We got another quality, and this girl is beautiful. She is just the nicest girl. I got to know her through my involvement with the girls soccer team, and just an unbelievable individual. And now she's done. She's done for high school sports.
Hmm.
And so my thought, and I'm not pointing fingers at anybody. I'm not doing that. I just think that these things could be avoided. Now, you see a lot of times, correct me if I'm wrong, where the other knee gets involved after one ACL. I've seen it up here 3 different times now.
Sure.
So, is it that the rehab that's going on is so hyper focused on the other knee that the uninvolved knee to begin with? I mean, I'm sure they're doing some rehab on that, but it just kind of gets lost and then predisposes to more stresses and loads on it because it can't handle it, and there you have the injury.
Yeah, I actually think I agree with that 100%. What's a shame with that is a lot of these doctors, they know better, and they still are okay with the imbalance of it. I think they're hyper focused on the one thing is just fixing that one problem,
Mm-hmm.
and not thinking about the future of where this athlete is going to go in the next 6 months to a year. And not to continue to plug the technology, but I will say, we've worked with a lot of athletes over the course of the years, and in particular, I've seen it recently in the last 6 months where, one of the good things about it is you're treating that one side, but now you're working everything bilaterally. So the healthy side is not being ignored. It's getting the same amount of contractions. It's one of the major reasons we do bilateral, because we don't want to ignore that healthy side. And I agree with you. I think the problem is it's so much focus on the injured side where before you realize it, now you have a problem on the other side because it's just been ignored.
Well, and the other thing too, it's a lack of screening. So if there was an injury on one side, to me, it only makes sense that maybe you'd want to get the uninvolved or the good leg screened just to make sure that it wouldn't happen.
Yeah.
And again, we're bringing this to people's awareness right now. I'm whatever has not happened in the past needs to stay in the past. But let's draw a line in the sand right now. Move forward. Parents, if you have a son or daughter that is in sports, and more, we have got to get the baseline screening, the baseline ACL screening done on them to make sure this doesn't happen. And Diane in my office, we sent out a patient communicator, a broadcast email, and I brought this up, and she saw the copy of it, and she goes, "Well, what are we charging for this?" I said, "We're not charging anything. I feel so strongly about this. We got to do this, and so that these kids are just not being tossed after they have an injury. We got to prevent these injuries." So.
Yeah.
So you got to call and get it scheduled, and let's get this taken care of.
And if I can, because I have no stock in Gaylord, Michigan at all, and I've worked with you up there. I love the neighborhood. I know there's a lot of athletes there. A lot of them are very serious. A lot of them are very competitive. One thing I can say is your office removes the why, and the why is, I think, one of those things that you don't realize until there's an actual action that happens where there is a torn ACL. And the beauty of your office is that you're kind of the preemptive strike, not kind of, you are the preemptive strike to injuries. So, unfortunately, I think people think that they can't go to you unless there's an issue. And I would impress upon anybody who's listening that if you're healthy and if your student athlete is healthy, now's the time to go in there and go through these evaluations. Remove the why, because the why is going to be a reason that you can go through all of this neurologically, you can go through the technology, and if there is going to be a breakdown, it's going to be that preemptive strike where your athlete is not going to be injured like they would have if they weren't going through this. So it's imperative that you do get treated before it happens.
Exactly. And then the other thing too is that I know that people do not equate a chiropractor with ACL. I know it's just not something that just comes to your mind. I go, well, why would I go to a chiropractor for anything knee related? Because they're the spine guys. No, we're not. I mean, I can adjust every single joint in the body if I need to.
Yep.
I do a lot of extremities. I've got a lot of, I call it the 3 E's. I got experience, I have education, and I got equipment. And nobody has that to the level that we have up here.
Yeah.
I just don't want to see any more kids have these injuries like this. Now, again, if it's a contact injury out on the court, on the field, those are going to happen. But these non-contact ACL tears have just got to stop. And so people are probably going to get tired of me just banging this drum. But until we start getting, we got to get a ton of people in. Because the other thing too, here's that now we can get data. We can get some normative data, and so we can start to comparing them from year to year, and we can see if there is a breakdown. This is nothing new in sports. Major universities and the professional level have been going to this. They've been measuring fatigue levels with their football players, and if they see that they're fatiguing, they're getting them out of practice because they know that when you fatigue, there's going to be injury. Well, we don't have the technology that those guys have, but we have some pretty cool technology that a lot of other people don't have, and we'll make the best use of what we've got, and it's still better than 95% of the other practitioners out there. So we'll do the kinetosense, we'll do muscle testing, computerized muscle testing, and we're going to do a scan with ARP therapy to see if there's a breakdown. It's pretty simple.
And I'd have to, I'm going to interject a little bit here and actually disagree with you a little bit, because I think you do have the technology that a lot of these pro athletes do. I mean, I've seen that I've seen some of these locker rooms. I've been in some of these locker rooms, and they have the same things. They have the Normatec, they have the brain tap, and they have ARP neurotherapy. And that's exactly what you're going to see in his office. So
nice.
Yeah, you're ahead of the game. I wish there was more offices like you. It's definitely forward thinking.
Well, like I say, every time you say that, that's one of the reasons we're doing this, because if there's doctors listening to this, why not? The question is why? Why aren't you call us? Give me a call, 989-448-8065. Let's talk about your office. If you're a potential patient, free consultations. I mean, the only thing that you may have to lose is the pain. Hey, how do you like that one? You like that one?
That's a nice tagline. I'm going to steal that.
Okay, I got to end on that one, guys. Hey, it's 33 minutes. Do we hit it again?
100%. Always. I love it. Time flies with you.
Thanks, Jake. And thank you, everybody, for attending the Neuro Way to Practice podcast. We'll see you next week.
Thanks a lot, Dr. Arkfield. We'll see you next week.
All righty.